Hello, I'm Diane Reidy-Lagunes, and thank you so much for joining us here today. It's truly an honor to be with you all. I was asked to talk about medical therapies for patients with neuroendocrine cancers and current clinical trials. These are my disclosures. I'd like to start off with two cases because often patients will tell me, well, I have another friend who has neuroendocrine and they told me their doctor did this, or my caregiver told me that they heard that the best treatment for neuroendocrine is this. And I think these two cases illustrate what we call the heterogeneity of the disease, why so many patients need a personalized approach because the disease does vary based on the patient, the biology, and the location of where it started. So case one is a patient with a small intestinal neuroendocrine cancer, 58-year-old gentleman who really had nonspecific abdominal pain, went to the emergency room and on CAT scan, thinking they would find gallstones, found bilobar liver lesions and a mass in the small intestine that was consistent with well-differentiated neuroendocrine cancer and confirmed by a biopsy that showed a low-grade tumor. This was the CAT scan, and if for those who are familiar with CT scans, you can see on the left-hand side there is the liver, and there are those white spots, which are small tumors that are neuroendocrine. So this patient, because we had what we call low volume disease, was actually watched with no medication for 14 months. And at 14 months, some of the tumors started to grow a couple of millimeters, as you can see there. One went from 0.8 to 1.5. And then we watched it a little bit longer, but then he actually did start octreotide-based therapies. And then 36 months after starting octreotide, still has stable disease. So that patient with a well-differentiated neuroendocrine in the small bowel maintains on octreotide for over 3 years. What about this patient that has a pancreatic neuroendocrine cancer? 60 years old, has some heart issues, some diabetes, some hypertension, and he did have a pancreas cancer mass with this white lesions, again, on the left side of the screen being the liver. And you can see there's a lot of them. And all that white is disease. And this was what we call an intermediate grade tumor. And this patient was symptomatic and was going to get into trouble. So this patient was immediately started on chemotherapy, which we'll talk about later, called capecitabine and Temodar. And the patient had an exceptional response and was on it for 9 months and then has been on a treatment holiday since for 3.5 years. So very different biology, very different approach for what we would consider the same disease, but really different because it started in a different place and it had a different grade and what we call a different biology of the disease. So every patient really does need, based on the data we have, to have the approach that would work best for them. So I always say location, location, location matters. So where the tumor starts and that burden of disease that I showed on those two examples really helps us guide the treatments. And this is just an example of all the different treatments that our patients with neuroendocrine cancers can have. Today, I was asked to focus on the medical, the ones that go systemically, or the medicines that we have to help our patients live longer and healthier lives. So what is the medical management of neuroendocrine cancers? Again, I said it's not a one-size-fits-all, but thank heavens we have many more treatments just today than we had just a couple of years ago. And we still divide patients into those that start in the pancreas and those that start outside the pancreas, because that's the way the trials are developed. And this is a little bit of a list of, as you can see, there's a couple of more therapies, including sunitinib for pancreatic NETs and chemotherapies as compared to the so-called carcinoid or neuroendocrines that start outside the pancreas. And we'll talk a little bit about that today. Where do we start? Well, what I call our first string players, the best medicines that we have for any neuroendocrine that starts anywhere. So first string players, I call them, are somatostatin analogs, and that's either octreotide or lanreotide. Why? Because they work well. They are a shot in the bottom once a month, and they stop the cancer from growing and spreading with very mild side effects. I sort of joke around, it's a pain in the bottom because you have to come in once a month, and it's an IM injection in the buttocks. But as therapies go, it's pretty well tolerated, and quality of life is incredibly important for our patients. Many of our patients can be on these for years. Which one is better? Because this comes up all the time. Is it octreotide or lanreotide? Biochemically, they are exactly the same. Same active site, meaning the same drug. It's just one's made by one pharmaceutical and the other one's made by another pharmaceutical. There are differences in formulation. One is what we call a deep subcutaneous, and the other one has to go into the muscle. So one goes into the skin, the other one goes into the muscle, although the gauge of the needles are the same. And we don't have any data comparing the two somatostatin analogs of which one is better. We know that because they are the same drug biochemically, if the disease grows on one, there's no data that you should go on the other, because again, they essentially are working exactly the same way, and I don't want you on a drug that won't be helpful because it's already grown through that. There is a difference in cost. So very importantly, you want to talk to your doctor to see which one would you potentially have a copay or not, because financial toxicities are also incredibly important, and we don't often talk about it enough. So in general, octreotide is a less expensive drug, although depending on insurance companies, sometimes they may be equivalent. So very important to talk to your docs about that part. What about, okay, I said location matters. So if we focus on the pancreatic nets, if you don't decide, I said before in one of the cases that sometimes we just jump to chemotherapy because we're worried about the burden of disease. Octreotide or lanreotide are generally first string players or first therapies when I feel comfortable that I don't need a good amount of tumor shrinkage, for example, because they work really well to stop it from growing and spreading, but they don't really shrink the cancer. So I talked before about we have chemotherapies that work for pancreatic nets. We also have targeted therapies. So these are two examples of targeted therapies that are approved, FDA approved for pancreatic nets that are progressing. And although these two drugs were not compared to each other, when you looked at the two trials, they both worked about the same. When you looked at what we call the progression-free survival. So how long did it take for the cancer to grow? So on average, when compared to placebo, both everolimus and sunitinib held the cancer at bay for about 11 months. They both, and sorry, this is sometimes written for clinicians as opposed to patients, but CR/PR is what we call complete response or partial response. So how many patients had major tumor shrinkage as defined by 30% or more? It's very few. So the response rates with targeted therapies are actually quite low, but they keep the cancer at bay. They shrink it a little bit and they prevent it from growing and spreading. So these are other therapies that could be very helpful if you have a pancreatic net. And importantly, again, the response rates are low, but they are oral drugs, which is nice because you could take them at home. They do have their own side effects. So everolimus may cause some mouth sores and may cause some diarrhea and some diabetes or elevated blood glucose, whereas sunitinib can cause what we call hand-foot syndrome, some fatigue, and some high blood pressure. So talking to your docs about these different side effect profiles and which would be best for you is very important. There's a new kid on the block called surufatinib, and this is the drug I wanted to share. It's now FDA approved in China and not yet approved in the United States, but the two pivotal studies actually took place in China. One was in surufatinib in patients with pancreatic nets, and the time it took to cancer to grow, again, the progression-free survival was close to 10.9 or 11 months. And the response rate here was actually a little bit higher than those other targeted therapies with a 19% response rate for surufatinib. So a little bit higher response rates, even though it wasn't compared directly to those other targeted therapies that I discussed, the everolimus or the Sutent. It also was tested in what we call extrapancreatic nets, so including small bowel, rectal, large bowel. And those patients also had an improved progression-free survival of 9 months. So these two pivotal studies led to the FDA approval in China and is now at the FDA, and they're reviewing this data. So look out for that, and we're expected to hear about it in this summer. So we're still on the pancreatic nets. Do chemos work? And the answer is yes. So traditional chemo, such as streptozotocin, is a drug which we call an alkylating agent, which can actually very well help our patients. It does have a lot of toxicities, so many of us don't use that one as often as we do temozolomide. Streptozotocin is an IV drug that has to be given pretty frequently. And temozolomide is in the same class of drugs as this streptozotocin, which is an older drug. It's called an alkylating agent, so they're all sort of cousins in the way that they work. And when the temozolomide was tested in combination, either alone or in combination with capecitabine, this study was a positive study. And actually, the combination of these two chemotherapy drugs caused the cancer to stay at bay for close to 2 years, which is pretty remarkable. So the progression-free survival, I mean, the time that it took the cancer to grow, was 22.7 months when you use the combination for patients that had progressive pancreatic NETs, which is wonderful. And it was a randomized phase 2 study, but it is on the guidelines. So we often will use this combination of therapies when we want a really good tumor shrinkage, because the response rates were higher than the traditional targeted therapies we just discussed, but the progression-free survival was longer. And the good news is that it is pretty well tolerated. The rare but serious side effects need to be considered, though. So again, as I discussed earlier, quality of life is so important to our patients. So we are always trying to sequence these therapies with a strong understanding that the quality of life has to be addressed when we're talking about our patients. So this is a therapy that we can and often use in our patients. And I tend to hold it in my cards after the somatostatin analogs or after the targeted therapies if the patients have lower volume disease. If they have high burden of disease and we need to start with a treatment sooner rather than later, this is my go-to. And what about peptide receptor radiotherapy? So another sort of home run for our patients with neuroendocrine cancers, and now FDA approved for all neuroendocrine of the GI tract. Although the study that led to its FDA approval was only in small intestinal neuroendocrine. So it's a little bit of a hard study, slide to understand, but essentially, if I can walk you through it, all patients with mid-gut or small intestinal neuroendocrines were randomized to either octreotide high dose, because they had already had octreotide, or the PRRT, which is in the blue box, and then they followed them to progression. Response rates were not as high, this is in small intestinal NETs, as we would have liked, but it is higher than other treatments that we use for small intestinal NETs. We just don't have a lot of great therapies that in small intestinal NETs will cause major tumor shrinkage, but the response rates you see here were about 18%. And if you look at this curve, the blue is what we call the progression-free survival. So the one on top is the one that it's just as they fall, that means that patients are starting to have their tumor progress. And essentially at 24 months, they were still stable. They hadn't met what we call the progression-free survival. So this is a home run, meaning that it was over 3 years actually for this study population where it took the cancer to grow. So a really good therapy for many of our patients, but there's no free lunch. And so what are the common risks? The common risks are fatigue, which is short-lived, but the most serious and concerning, albeit very rare, is the potential for damage of the blood counts. So 1 to 2% can get what we call myelodysplastic syndrome, or MDS, which is pre-leukemia that can transform to leukemia. And that's because this radiation can actually bind to the stem cells in our blood and potentially cause that damage. And we don't know yet who is at higher risk. We know patients that are heavily treated may be at slightly higher risk, but we really have not defined the patients who are going to have that very rare but serious side effect, which is one of the reasons why we don't use it at the starting gate, but we wait and we use those other therapies that I discussed that are a little bit gentler with less side effects in terms of the very rare but very serious problems that can arise. So how do we decide on the sequencing of which one we use? Again, unfortunately, there are no great data to tell us which ones are better. We don't have data, so we have to take a personalized approach, which is why I really encourage you to go to a center of excellence where there are folks with neuroendocrine cancers that understand this disease. The only sort of sequence we do know is that on that NETTER study that led to the approval of PRRT, you had to have been on octreotide first. So as I said before, octreotide in general in patients that don't have a lot of symptoms and don't have a lot of disease burden is our first option to consider. And then these other therapies that we discussed would be going after that. A word on the carcinoid syndrome, because it's such a debilitating side effect for many of our patients. There is a drug called telotrestat. Telotrestat was tested to help carcinoid syndrome diarrhea. It's not a drug that helps cure the cancer or treat the cancer. It's not even what we call an anti-neoplastic. But what they did is they randomized patients who had bad carcinoid syndrome diarrhea to different doses of this oral drug. And then they followed them to see, did it improve in the number of bowel movements they have? So it's a little bit of a difficult slide to read, but essentially, on average, the patients on the 250 milligram dose, for example, had about 6 bowel movements a day. And when they took the telotrestat, it went down to about 4.2. So it's not a home run, but for many of our patients that really do have debilitating diarrhea, it can be helpful to potentially add in if you have diarrhea from carcinoid syndrome diarrhea. Many of our patients have diarrhea from lots of other reasons. So you just want to make sure you speak to your oncologist and understand that it's truly from the carcinoid syndrome and not, for example, reasons for the cancer or surgery or other reasons or causes for the diarrhea itself. So I wanted to just give a shout out for one study that we presented this year where we're also using lanreotide for LACNETS. So many of our patients that have neuroendocrines that start in the lung don't have many studies to test the benefit there. And this was a study that proved that the progression-free survival for lanreotide was higher than when compared to placebo. This study did have to be closed a little bit too what we call prematurely or early for poor accrual. So although it was very clear that the patients in the lanreotide arm did better, it wasn't necessarily powered because we had to close the study early, but it is thankfully on the NCCN guidelines. So patients with LACNETS should also be considered for lanreotide or somatostatin analogs as a first-line therapy when they have low-volume disease. I also wanted to throw out this drug, which is now FDA approved, which is very, very important for our patients with neuroendocrine that have an inherited gene that causes von Hippel-Lindau syndrome. So for those of you that have the VHL gene, which is very rare, but very, very important to know. So if you have a family history of pancreatic neuroendocrine tumors or kidney cancers or something called hemangioblastomas, please talk to your doctor about the possibility of needing to get genetic tested. Why? Because this study of an oral drug called belzutifan, 120 milligrams daily, took all patients that had VHL and they looked to see, did they respond? Now, most of these patients had kidney cancer, but it turns out because they had this gene, they also developed pancreatic NETs, which is a very common problem in patients that had this gene. And when they looked at patients that had pancreatic neuroendocrine cancers that took this drug, over 83% of them responded, and the duration of response, meaning how long did it work, it's still working for the vast majority of them. So it's a home run because it's going right to the driver of the cancer, which is called hypoxia-inducible factor, and it will kill the cancer in that way. So very important in this rare patient population that has this gene to be considered when the cancer grows. Many of these, thank heavens, are actually very slow growing, so they don't need cancer therapies right away. But when it does, we have this magic bullet to be used. Okay, I'm going to shift now to the current landscape of neuroendocrine trials because, again, the good news is there's lots of stuff going on. We have new drugs, as I said, that are already FDA approved or will be soon FDA approved. And we're constantly trying to think about our patients of tomorrow and sort of run in front of the bear to make sure that we have more trials as patients can live longer with this disease and we need more options. So there are a lot of studies across the world, and I just gave a handful of them here today. Many adding to the somatostatin analogs, which I said were the first-line therapies, to see can we improve response rates and or progression-free survival. There's also a very important study in the United States called RETNet for those of you that have undergone embolizations. This is a trial to ask the question of which embolization is best. Is it chemo embo versus bland embo? So those results will be very important. There was one arm that had drug-eluting beads, which was closed because it was too toxic. So any patients that are being considered for drug-eluting beads should not be getting that for neuroendocrine cancers. We do have other small molecule or targeted therapies and combining either everolimus or chemotherapies or octreotide plus a drug called axitinib. So several studies that are being tested to essentially trying to add to the current therapies to see if we can do better. I can say though, in the world of cancer therapies, often, particularly like our patients and our diseases, more is not necessarily better. And again, eye on the ball, always about quality of life needs to be really important. Cabozantinib is just going to give a shout out for this phase 3 registration trial that is open in many sites throughout the United States. It is a phase 3 study, what we call randomized to placebo, meaning cabozantinib being an oral targeted therapy. You have a 2-to-1 chance to be randomized to the medicine. If you're randomized to the placebo and it started to grow, you can cross over. And this is a drug that has already shown some benefit in a few studies for neuroendocrine cancer. So this is the study that will lead to its FDA approval if positive. And so far the data is exciting and we're looking forward to accruing more patients for that. You can't really give a study talk with a neuroendocrine or anywhere else without immunotherapies in 2022. But unfortunately, although we do have several different trials, if you will, in neuroendocrine cancers looking at the role of immunotherapy. Many of these trials have not really come to fruition. The atezo-bev study from MD Anderson, I will say, was recently reported, and it did look like it met its primary endpoint, which is exciting. So bevacizumab is what we call a targeted VEGF inhibitor with the combination of atezolizumab, which is immunotherapy. We just don't know which one was the one that may have been more active. Or was it both? Was it atezo, the immunotherapy? Was it bevacizumab that's already shown some promise in neuroendocrine? Or was it the combination? But this is a new study that just recently came out. So excited to see more work on that. But again, in general, unfortunately, immunotherapies in neuroendocrine cancers have not panned out to be as helpful as we'd wanted. And then last but certainly not least, there are several studies across the world looking at PRRT, peptide receptor radiotherapy, with other combinations of therapies, whether it's liver resection in what we call the adjuvant setting, so giving it after treatment, after surgery, which could be very promising and exciting, combinations with chemo plus PRRT and or with targeted therapies. And I've chosen some select studies here that we have in the United States that are, again, either comparing to the standard of care treatment arm to say which one is better. So for example, lutetium dotatate versus sunitinib, or versus everolimus, or versus best of standard of care, which is chemotherapy, which is what we call the compose. So lots of different studies that are trying to ask the question for us, how should we sequence them? Which one is better? And so if you find which one is better, maybe then you use the other one for the next line when that one stops working. So these are going to be super important for us to better understand how do we sequence and how do we put these therapies into different places for our patient population. So in conclusion, the treatment landscape, thank heavens, has continued to widen and change dramatically in the last 10 years. I'm really hoping the next 10 years, these trials that I discussed will help us to know when to give what therapies and how. And then we also desperately need what we call predictive markers to know for any one person, what's the best personalized approach for that person? What's the therapy that's going to do best for them and in what order? We haven't gotten there yet, but there's actually a lot of work going on to do that. As I said, location matters. So the GI nets, the so-called small bowel, is not the same as pancreatic nets. So often we'll use a lot of chemotherapy, traditional chemotherapy for pancreatic nets, which we really can't do as well or successfully in GI nets, although there are exceptions to that. We didn't talk about surgery today, but I will say that surgery is something that must and should be considered in the localized setting. But these systemic approaches that I talked about are all appropriate trials, and these clinical trials that we discussed will add to adding additional therapies and or helping us know what are the backbones of treatments that we need. So last but certainly not least, it definitely takes a team approach, and this is our team of neuroendocrine experts here at MSK. But we're also, first and foremost on the teams for all of our patients and their caregivers. So thank you for being with me today.